Thank you. It's my pleasure to be here. As Albert said, I've been here almost 2 months now, and it's really great to speak to you all about some of the work that I've done in the past about HIV and the immune system. Most of this work was done in San Francisco when I was at UCSF, and really to talk about the interaction between HIV and the host immune response. So this is not a big history of HIV, but the things that are striking for me is sort of the timeline here. In 1981, the first cases of PCP and Kaposi sarcoma started to be recognized in major metropolitan areas in the United States, both on the East and West Coast. It was recognized a year later that this syndrome was characterized by immune deficiency, and the term AIDS was coined, acquired immunodeficiency syndrome. And just a year after that, the virus that caused AIDS was identified. And just a little bit about industry, I guess, since I've been there. 3 years later, the first drug for HIV was developed, and that's really remarkable to say. The clinical entity was described in 1981, and the first medicine was available in 1986. Unfortunately, it didn't work, and HIV has actually contributed probably the most to our understanding of viral resistance, and the virus becomes resistant very quickly, and patients continued to die. And in 1991, it became the leading cause of death in young men in this country. And in 1996 was really when we developed what has been coined HAART, highly active antiretroviral therapy, which is essentially a combination of medicines that attack different proteins on the virus, preventing the development of resistance. And that's when we see, this curve that we've seen so many times, where we see the rise in death toll from HIV and AIDS until 1996, and then this dramatic decline. Which has continued now to the present day. And why, when we see patients in clinic, I think all of us, when we see new AIDS, HIV-infected patients, always say it's no longer a death sentence. I think everyone has used those words. But I added these last two things to the timeline because I think the work is certainly not over. And in terms of immunology, especially there in 2006, I think the community was quite saddened that a very large vaccine trial, the Merck vaccine trial, failed, along with a lot of other smaller vaccine trials that have still failed, which sort of highlights the fact that we really don't know what immune response is necessary to prevent this infection. And in terms of the impact and the ongoing impact, there are still 1 million people in this country infected with HIV, 33 million worldwide, 2.7 new cases yearly, and 2 million deaths annually. And so what are the priorities for HIV care and research now? I think that access to care and access to medications is a huge one. I don't think I need to tell this audience about that, but a third of folks that should be getting medicines don't have access to those medicines, and we're talking about 10 million people. The prevention of new infections and the treatment of comorbidities is also key in terms of treatment of patients. But the things that I'm going to talk about today are sort of the key research topics for HIV immunologists, and what has sort of been the focus recently in terms of understanding the immune response to HIV. And that is, one of the big goals for researchers are continued efforts in vaccine development, and now a renewed effort in actually trying to cure HIV. And so the first part of my talk will be to try to understand what are the immunologic complexities of the host response that may or may not allow us to get to these points. And then the second issue is non-AIDS related mortality. As I said, there's more people living with HIV now than there were 2 decades ago. And despite antiretroviral treatment, we're seeing mortality and morbidity from non-AIDS causes, and how much of that is actually due to the consequences on the immune system. So this is usually 2 different talks, each of which takes an hour. So I'm going to try to hit the highlights here to give you a flavor of the things that the field is grappling with. So I think in terms of the natural history of HIV, so in the absence of treatment, what we see here in orange, after an individual gets infected, we usually see an initial burst of HIV viral replication. We see HIV RNA copies up to the 10 to the 6th in terms of copies per milliliter, with wide dissemination of the virus to multiple compartments, with a subsequent drop in viral load, and then most individuals attain some sort of viral set point, which lasts for 8 to 10 years, and then the virus comes back again, rising to high rates of replication. At the same time, the CD4 T cell count, which are the cells that HIV actually infects and depletes, they fall dramatically, actually, initially after infection. Some of that is due to redistribution, but some of that is clearly death of CD4 T cells. They make a slight rebound, and then over the next 8 to 10 years, we see the slow decline of CD4 T cells. And when they get to what we call a critical level of about 200, we start to see an increased rates of opportunistic infections, malignancies, and along with that rise in viral load and untreated, that will ultimately result in death in the patient. So this is, again, is what we see in the vast majority of folks in terms of the viral load. Goes up, attains a set point, and then goes up again towards the end of disease. What was recognized relatively early on in the epidemic is that there were about 5 to 10% of individuals who actually didn't follow this trajectory, that they did have that initial rise, but then their viral set point was lower, and they did not, they survived for a longer period of time, and we didn't see that viral rebound until several years later. But eventually, they did have a rise in viral load, and eventually they did have drops in CD4 T cell counts. And these folks were coined long-term non-progressors, making up about 5 to 10% of the population. And they were really defined not by the virus, but by their ability to maintain CD4 T cells. And then just in the last 5 years or so, a new group of individuals have been identified and now extensively followed. These folks have been coined elite controllers. They make up less than 1% of the infected population. And we now know from early infection studies that they do have a viral burst initially, but then they're able to essentially get their virus down to undetectable levels in the absence of any therapy. And this is a durable suppression in some individuals over a decade of being infected with HIV, but we're not able to find the virus in their blood. Why does that matter? Well, we know from very early on that what your viral set point is predicts your progression to AIDS. So those with a viral load of 1,000 copies, this is from David Ho's work back in the early 90s, that showed if your viral load was very low, your likelihood of progressing to AIDS in the absence of therapy was essentially zero. And that has largely been the case for elite controllers. They've maintained their CD4 T cell counts, and except for rare exceptions, they do not get AIDS and they do not have T cell decline. So the majority of elite controllers don't progress to AIDS. So should they be a model for functional HIV cure? And they've been now, just in the past 5 years, studies extensively to see if we can mimic their host response. So how do they maintain their control? And there's always a debate between virologists and immunologists about what is more important. So one question that was asked early on is, are they really infected with the virus? How do we know? We know that they're seropositive. That's how they're defined as HIV infected. And folks looked at their DNA, their cells, as well as looking for ultrasensitive measurements of viral load in their plasma, and they have both. So they certainly have remnants of the virus somewhere in their system. So they certainly saw HIV. But then the question was, well, is that virus really, able to replicate as other folks' viruses are? And some of them actually do have large deletions and mutations in their virus that make them less fit. But there's a significant number of folks where replication-competent virus has been isolated from their blood. As you can imagine, this is really difficult to do. You essentially have to do a leukapheresis in these patients to actually find the virus, stimulate these cells extremely vigorously to get that virus to come out, but folks have done it. So certainly a certain percentage, and probably we think now the majority of elite controllers actually have replication-competent virus somewhere. And I think even more compelling are transmission pairs. So now we've identified folks where there is a individual who actually is a non-progressor, has replicating virus, has transmitted the virus to the partner, and that partner is an elite controller. So we do think that these folks are infected with virus. So then there's also a focus on the host then. What is it about them that allows them to control the virus? Is it the adaptive immune system? Is it the innate immune system? Is it their ability to maintain lower levels of T cell activation? And that's what I'm going to talk about now. So the studies that we did when we first started to identify these individuals, there's a relatively large cohort in San Francisco called the SCOPE cohort. Over 7,000 patients are followed longitudinally. Basically, anyone that wants to be in the cohort largely can be. And every 4 months, blood, saliva, and I think for a while, semen has been stored on these patients so that you can actually follow their responses, their virus over time. And so what we did was we took cells from these individuals and stimulated them with HIV peptides to see what type of immune response to HIV these individuals manifested. So the groups of individuals that we studied are elite controllers. So essentially they have documented low viral loads off of therapy. And then we have 3 comparator groups. There's viremic controllers, which are almost a version of elite controllers. They have slightly higher viral loads, detectable all the time, but they're also off therapy. These are almost like your traditional long-term non-progressors. So they have virus around, they don't control as well as the elites. Then we have non-controllers. So this is like the vast majority of the untreated population. They have high levels of viral load. And then the last group, which I think is a very important comparison group, are folks that are on therapy with suppressed virus. So the virus does a whole lot of stuff when it's around to the immune system. So we really wanted this population to control for the level of virus to allow us to really look at the immune system in the absence of viral replication to make those comparisons. So just in terms of the demographics, they were all essentially all groups were in their mid-40s, infected for a relatively long period of time, most of them over a decade. If you look at their CD4 T cell counts, and we didn't choose these groups based on T cells, but based on their virus, elite controllers have a nice, this is actually a normal CD4 T cell count in the 700s. These are median values. Controllers are slightly lower in the mid-400s. As you would predict, patients with high-level viral replication, their CD4 count is in the 200s. We purposely didn't pick individuals that have very low CD4 T cell counts because they're really towards the end-stage disease, and that can impact your immune system in various ways as well. And then folks that are suppressed with therapy have about a CD4 count in the mid-400s as well. So the first thing we looked at was T cell activation in HIV, and why do we care about T cell activation? So essentially this is a measurement of a couple of markers on the surface of CD8 T cells, CD38 and HLA-DR. CD8 T cells that have these markers are activated. Most of them are not infected. Well, the CD8s are not infected, but even CD4s with these markers are not infected with HIV. This is bystander activation in the setting of high levels of virus. And back in the 90s, Janice Georgi from UCLA actually showed that T cell activation was a better predictor of mortality from HIV than viral load. And we know now that T cell activation actually predicts your ability to respond to antiretroviral therapy with CD4 gains. So when we looked at elite controllers, we can see compared to the viremic controllers, so these are like your long-term non-progressors, they have a significantly lower level of T cell activation compared to those controllers. Not surprisingly, patients with high-level viral replication have really high levels of T cell activation. This is 40% of your T cells. CD8 T cells actually look like they're, freaking out, basically. I mean, there's nothing that they're not HIV specific. This is just bystander activation. They're acting like they're ready to fight something. And that's not surprising, and that's been reported before. Now, if you look at individuals that are suppressed on therapy, you can see when you go from an untreated high level of viral replication to treatment, your T cell activation drops dramatically, and people have reported that before. Now, if you compare these two groups, now both of these groups don't have much virus around, your elite controllers actually have slightly higher T cell activation than folks on therapy. And to me, this is actually another piece of evidence that these folks are infected with virus. There is viral replication going on somewhere. It might not be in the blood, but this is not a normal level of T cell activation. And here's your HIV negative group. So whether you're on therapy and suppress the virus, or whether you're not on therapy and suppress the virus, your levels of T cell activation are not normal. So something is going on somewhere that's making your CD8 cells not completely happy. So after T cell activation, we wanted to look at the HIV, the T cell response to HIV. And we looked at the literature. There's a lot of literature about long-term non-progressors. They have very robust CD4 and CD8 T cell responses to HIV. We know that remember that first slide where the viral load is up and then it drops suddenly about 4 to 6 weeks after infection? Well, there's a very strong correlation with the drop of viral load and the rise of HIV-specific T cells. We know in the macaque model, if you actually get rid of CD8 T cells, your viral load goes through the roof. And then we and others have shown that dual functional T cells, those that secrete both interferon gamma and IL-2, are actually associated with good viral control. So we started with this and said, well, let's look at the T cells in elite controllers and see if they control in the same way as the long-term non-progressors have. And I would say essentially the answer looks like it's yes. So if you look at your elite controllers and your viremic controllers, they both have, this is a GAG protein. We've done this with envelope, with NEF, so multiple HIV proteins. But GAG is the most robust peripheral response. So you can see that, there is nice T cell, CD8 T cells, and these are CD4s. And you can see it's much higher than what we find in individuals that have high levels of virus, so the non-controllers. And interestingly, once you go on therapy, you actually largely lose your peripheral HIV response because there's not a whole lot you're reacting to. So when you take the cells out of the body, there's not a lot of HIV specific responses out there. So essentially, we've shown that elite controllers and viremic controllers do have this robust CD4 anti-HIV response. And the same is true when we look at CD8s. Again, these are the dual functional CD8s that secrete both interferon gamma and IL-2. Elite controllers and viremic controllers clearly have higher T cell responses compared to all of the other groups. And this is just our HIV negative control, which understandably there's no response to HIV there. So it looks like, okay, well maybe this is why they're elite controllers. They have these great T cell responses. This is something we've known all along, and this might be what we should aim for in a vaccine or when we think about curative approaches. But and I think as many folks in the audience know, how you show the data makes a big difference. So if you look at the actual individuals that were used in this analysis and you look at the spread, the higher levels of T cell response in these two groups are really not driven, by the whole group. There are some folks that have no HIV-specific T cell response, and yet they still control the virus to undetectable levels. And this is, a sizable proportion of both the elite controllers and the viremic controls, and they look just like the non-controllers and heart-suppressed individuals. And so the next question we asked is, well, why is that? Are these folks different than these folks in some way, and do they control the virus in different ways? So we focused then on HLA. So HLA molecules are on the surface of antigen-presenting cells. They're responsible for binding foreign things, sometimes self as well, bacteria, viruses, and essentially they present the peptides of that foreign protein to CD8 T cells. And the T cell receptor on the CD8 T cells recognizes the combination of the HLA molecule and this little piece of bacteria or virus that's there, and then goes on to kill that cell that's infected. And there's huge genetic diversity in terms of your HLA. Everyone here has their signature HLA type with lots of different variants. And actually very early, when people were looking at HLA in HIV, we knew that there were some HLA types that were associated with a better prognosis to HIV, a longer or delayed progression to AIDS. And those, in the literature, if you look, HLA B57 and B27 are the ones that are most often cited. There are others, B13, B58, B81, all of which have been associated with long-term non-progression. So we looked at our cohort and we said, you know, within the elite and the viremic controller group, what is the prevalence of these protective HLA alleles? And you can see that there is a higher percentage of protective alleles in the elites and the viremic controller compared to the non-controllers. And then we asked, well, is the T cell responses and the heterogeneity that we saw, is it explained by HLA? And it seems to be, when you look at the data this way. So we looked at the controllers that have a protective allele compared to those that don't have a protective allele. And we looked at that, you know, optimal dual functional CD8 T cell response that we're aiming for. And you can see that those that do have a protective allele have a significantly higher T cell response compared to those that don't have that T cell response. And when you look at the non-controllers, there are some folks that have those good alleles in the non-controllers as well, but universally all of the non-controllers have poor CD8 T cell responses. And there's no difference between those that don't have the controllers versus the non-controllers that don't have protective alleles. So what that basically says is if you have an HLA, protective HLA allele, it's not necessary for good control of the virus, nor is it sufficient for control of the virus. You really have to have you know, the right HLA type with a good CD4 response to really fall in this controller group. But what was really intriguing is that there are a bunch of people that don't have protective HLAs, don't have good CD4 T cell responses, but still control their virus to undetectable levels. And so that's where my story ended, and that's when I left for Genentech. But it's interesting that, you know, this question is still a very active question in the field of HIV to understand this heterogeneity in the elite controllers and what are the aspects of the immune response in these folks that actually allow them to control virus, and are there aspects in these folks that we can actually mimic either in a vaccine strategy or an eradication strategy. So in terms of a summary of the elite controllers, they maintain tight viral control of viral replication despite being infected with a replication-competent virus, but they're a very heterogeneous group. You know, now you're talking about less than 1% of your HIV-infected group, and there's heterogeneity within that as well. We think that HLA alleles, they're certainly enriched, but they don't explain the whole picture because they're neither necessary nor sufficient for viral control. So I think the way that I try to think about this, and I don't want to ignore the fact that there's viral diversity either, but I think in the elites that there probably are a group of them that are infected with defective virus, replication incompetent virus. And so they're seropositive, but they actually don't have an ongoing viral replication. There's probably another group that is infected with virus, and they have a strong T cell response either due to prior exposure or just because they have a protective HLA, and that allows them to kill the virus prior to CD4 infection, or more likely that they have a low-level infection and the CD4 T and CD8 T cells keep that in check. And then I think what we're really interested in learning is that there's probably a group that have other arms of the immune response that actually allow them to control their virus, that either initially during that initial burst can control the virus, or it lowers the peak viral load enough to let the adaptive immune response sort of take over. So are the elite controllers a model for cure? I would say maybe. But they're a small, unique group, and they do represent the ideal response to HIV infection, and we're trying to mimic their host responses. But I think we're relatively early in terms of understanding the elite controllers and understanding the diversity, and it's going to be really important as we tease out the optimal immune response to make sure that we don't group the elite controllers into one entity, and trying to understand which of their immune responses we can actually mimic. One thing I will say is that we can't really mimic the protective HLA strong CD8 T cell response, because we either have B57 or we don't. And though we can't really mimic in every individual a strong B57 mediated immune response, because everyone can't do it. So which is why I think this, if we can mimic this side, that will be something that is potentially achievable for a larger percent of the population, but we're still trying to understand what that side is. So that was part one in terms of the complexities of the HIV response. Now I'm going to turn to the consequences of HIV on the 90 to 95% of individuals that are infected with HIV and aren't lucky enough to control their virus in the absence of therapy, but actually need therapy. And as I talked about before, the number of individuals living with HIV continues to rise, given that we have 2.7 million new infections a year. The antiretroviral therapies, if you have access to them, actually work. And so the number of people living with HIV continues to rise. This is another version of the slide I showed before with the dramatic fall in mortality, but this is divided into mortality that is related to AIDS-related causes versus non-AIDS related causes. And it's hard to see because the black is so low compared to the AIDS-related cases, but you'll have to trust me when I tell you that the rates of morbidity and mortality from non-AIDS related cases has never dropped, even with the institution of highly active antiretroviral therapy, and now looks like it's probably rising as this population continues to age. What is that morbidity? It's cardiovascular disease, liver disease, kidney disease, metabolic disorders. We're seeing hyperlipidemia, increased rates of diabetes. We're seeing osteoporosis, and we're seeing particular malignancies that are increased in incidence. And not only are these increased in incidence, we're also seeing a lot of these conditions at a much younger age than you would expect in an HIV uninfected counterpart. So cardiovascular disease, for example, individuals are having thrombotic strokes and heart attacks at least a decade earlier than you would expect once you control for risk factors. And some of these conditions have been associated in the non-HIV population with alterations in the immune response. So what I wanted to look at is, once you put individuals on therapy, what parts of their immune response gets better and what parts don't. And so I'm going to talk about some of the measurements that we looked at, including CD4-CD8 ratio, naive T cells, CD28 expansion, and then talk a little bit about the similarities between HIV disease and aging in terms of the immune system. So the groups that we studied here, once again, this is our main group now, which is the antiretroviral treated individuals who are suppressed on therapy and have been suppressed on therapy for some time. To compare that with individuals that are not on therapy and have high viral loads. And then I think what is increasingly being recognized is now that we're able to get virus undetectable, we have to really get very well-controlled HIV negative groups to see what is that continued residual difference in these controlled groups. So this is again, individuals largely in their 40s, non-controllers and heart suppressed, been infected for a median of 15 and 10 years. You can see the CD4 count is higher in those that are antiretroviral treated, and of course their viral load is undetectable by definition. So the first thing we looked at was just numbers of CD4s and CD8s. Normally we should have twice as many CD4s, those are our helper T cells, compared to CD8 cells. And we know in the non-HIV population, when that ratio gets flipped, when you have more CD8s than CD4s, that's actually a predictor of mortality. And we also know, we know that T cell activation is bad for HIV. We also know that this inverted ratio is directly correlated to your levels of T cell activation. So what we looked at was HIV negative individuals, and these individuals were somewhat matched to our HIV infected group in that they, in terms of demographics, these were individuals that were presenting for post-exposure prophylaxis after high-risk behavior in San Francisco. So you can see in the HIV negative population, this is the normal CD4 to CD8 ratio, twice as many CD4s compared to CD8s. You can see in individuals that are have replication of their virus and are not on therapy, dramatic drop. I mean, this is a 1-to-4 ratio in terms of CD4 to CD8s, and this has been reported as early as the late 80s, that this is what happens when you don't treat HIV. What we would have liked to see when we put folks on therapy is that you go, right back up there. We don't see that, but we certainly see a statistical increase in your CD4-CD8 ratio, but it's still 0.5. It's still inverted. So then we looked at the CD4s and CD8s separately to see which aspect of that ratio is driving this response. So we know that when you're not on therapy, your depletion of CD4s is really dramatic, as is the increase in CD8s. And this happens pretty early after infection, which explains that ratio of 0.25. Though you gain some of your CD8s back, CD4s back when you go on therapy, you don't really lose your CD8s, which is why you have this persistent lower ratio. And we don't know yet whether that is good or bad, but it's just an observation at this point. So we wanted to look at those CD4s and CD8s that remain and to say, well, is there something different about them that we should be concerned? So one thing that we wanted to look at is we did T-cell subsetting. So essentially, when you have a T-cell, CD4, CD8, it's when it comes out of the thymus, it's a naive cell. It's just hanging out, waiting for a pathogen, a tumor, something to respond to. When it sees that antigen, it begins to differentiate. And a bunch of cells become effector cells. And those are basically your killer T cells. They're out there to kill the cells that are infected with virus. They're out there to kill the tumor cells. And once they've done that, then most of them die. And then a few of them revert to a memory population waiting to see that virus again. And then there's another group of naive cells that will actually immediately go into that memory population, knowing that maybe this will happen again. And then eventually, after the antigen is cleared, then there's different phenotypes of these memory population that essentially manifest with different functions. So your naive cells, they're able to proliferate really well. They secrete IL-2. Your effector cells secrete perforin, granzyme, interferon. These are cytokines that essentially have the ability to kill their target cell. And then you have this memory population that's sort of a combination of the two. They proliferate a little bit. They secrete some IL-2. They can secrete interferon gamma. But these subsets of cells are essentially, they're there to be able, these cells are there to be able to proliferate in the setting of a second infection, and they're also there to be able to kill pretty quickly if they need to while we're waiting for that effector response. So we used 4 different markers to identify our T cell subsets, and I've just laid them out here from what I consider naive to memory or effector populations. And we used 4 because we wanted to be really confident that these are naive T cells, so we used a bunch of markers. And we wanted to be really confident that these are effector T cells. So we used, at the time, what was really sophisticated multi-parameter flow cytometry to be able to identify these cells. So these are HIV uninfected individuals, and you're looking at their CD8 T cells. And you can see the vast majority of your T cells are naive. They're just hanging out. They're not facing any sort of problem right now. They're just waiting to see that next infection. In the setting of HIV, these are folks not on therapy. You see a dramatic drop in your naive T cell population, and you see a big increase in these effector cells. Well, they have a chronic infection. They have a virus. All these cells there's more and more effector cells. These naive cells are constantly proliferating and differentiating into these other subsets. When you go on antiretroviral therapy, you're essentially taking away the infection. So what I think we would have liked to see is that then you get your naive T cells back and your effector T cells go away, because you really don't need them right now. And this is what we saw, and I don't know why my error bars are not on there, but we do have error bars. But essentially, there's absolutely no change. Even though you've taken away your antigen, and these effector cells should largely die off, they don't seem to, and you're not getting your naive T cells back. And that was striking and of concern, because now we know what naive T cells do. They respond to cancer, they respond to new invading pathogens, and we know that as you age, you lose these naive T cells, and that's associated with sort of badness over time, because you're not able to appropriately respond to the infections that you should be. We looked at this another way in terms of CD28. CD28 negative T cells are essentially what we call, they're not only senescent cells, but they're also reflective of a senescent person. So as you age, you get more and more CD28 negative T cells, and you can see again in HIV, you lose your CD28 positive, you gain your 28 negative, and essentially again unchanged in the setting of antiretroviral treatment. And interestingly, Rita Efros, who's also at UCLA, looked at the telomere length of individuals with HIV, and essentially they were, which again is a marker of senescent, and they were equivalent in length to HIV uninfected individuals in their 90s, essentially. So just in summary of the consequences of HIV on the immune system and the persistent impact of HIV on the immune system despite therapy. So we see there's continued decrease in inversion of the CD4-CD8 ratio. There's continued decrease of naive T cells. There's persistent CD28 negative expansion. I haven't shown you the data, but there's also increased secretion of these effector-like cytokines, and there's increased CMV-specific responses, also has been associated with senescence. And now I'm going to tell you what happens in the literature for when you look at individuals in terms of extreme age. Inverted CD4-CD8 ratio, decline in CD4 T cells, lower naive memory T cell ratio, accumulation of CD28 negative cells, increased production of interferon gamma, decreased production of IL-2, increased CMV seropositivity, and increased levels of pro-inflammatory cytokines. So essentially all of the phenomena that we see in HIV, both untreated and treated, is what we see in the aging population. And I've sort of highlighted the ones that there's a clinical correlation with. So the inverted ratio, the accumulation of CD28 negative cells, and the CMV-specific response have all been associated with increased mortality in the non-HIV population. So what does that mean, given that our HIV population is increasing and our HIV-infected population is aging? And these are the questions that many people are looking at, which is, does HIV actually cause premature aging of the immune system? And do the phenotypes that we have identified, and maybe some other aberrancies that we haven't looked at yet, are they actually correlated to clinical outcomes in this patient population? Do they improve with time on therapy? So, our folks were, treated for anywhere from 3 to 5 years. Well, what if they've been treated for a decade? Do they get better? Does earlier treatment, so maybe if we didn't wait till their T cells were 50 before we treated them, but we treated them when their T cells were 400, maybe we wouldn't see that. And then what's the contribution of the therapy itself to these aberrant responses? And some of the things that we're doing right now is trying to address some of these issues. We're now with the YACS cohort, which is based out of the VA here. Dr. Amy Justice is the PI of that cohort. We're looking at carefully controlled studies of HIV-infected and uninfected individuals, because what I showed you was not controlled for age, which is obviously a very important variable to look at. We're also looking at the association of these phenotypes with clinical outcomes. So do individuals that have cardiovascular outcomes have particular immunologic phenotypes that could predict that, or individuals with particular malignancies? And we're also looking at longitudinal evaluation of patients on heart, because we do have now the ability, everyone's staying on antiretroviral therapy for years. We can look at individuals 3 years later and every 3 years if we wanted to see when we see the change in the immune system. This is essentially a flavor of two of the big areas of HIV research that's going on, and translational research of HIV and the immune system. And some of the stuff I'll be continuing here at Yale. But I do want to acknowledge the folks that helped me generate this data back in San Francisco. Mike McCune and Steve Deeks were my mentors during fellowship, as well as Doug Nixon and Jeff Martin, who also were involved with the SCOPE cohort. Walter Moretto in the lab that helped me do a lot of those studies, and other folks all involved with the Positive Health program at San Francisco General Hospital. Thank you.